Welcome back, everyone. For this lecture in the assessment series, we're going to talk about vital signs. So up to this point, we've covered the EMS phases of a call as an overview. We've covered the primary assessment. We've covered the scene survey, and we've talked about transport decisions. Now let's talk about vital signs. Vital signs, history taking, and secondary assessment all come after the transport decision. And in the phases of the EMS call, these may be interchanged depending on the patient presentation, the environment, and what's going on at the time. There's no particular order for each of these. Myself as a provider, I like to have my vital signs as I'm starting the history process. So this may be sort of double duty, if you will. I may start getting vital signs while I start interviewing the patient or the bystanders, or I may instruct my partner to start getting sets of vital signs while we start that history process or that physical exam process. So understanding that this entity comes after your transport decision is important, but the order in which it comes in following that may change based on your patient presentation. So with vital signs, we're going to talk about a couple of things. One, vital signs, and the word sign indicates that this is an objective measurement. And what I mean by that is this is a process in which you actually are going to obtain quantitative data. So numbers, ratings, things that can be measured, as opposed to your history, which is subjective data. And in your history, you're going to have information like how does the patient feel? Okay, that's qualitative data. The vital signs are quantitative. They're typically numerical and they're measured. You have a lot of tools you're going to use to obtain your vital signs. The first tool is you, the provider. Your senses, your sense of sight, your sense of touch, your sense of smell, and your sense of hearing are all going to be the most powerful assessment tool that you have. Okay. You're also going to use a stethoscope, a blood pressure cuff, pulse oximeter, glucometer, and cardiac monitor, depending on your service or your level of practice. Things that we're going to be assessing are your level of consciousness, your pulse, your blood pressure, your respiratory rate, your saturation percentage of oxygen, or SpO2, and your blood glucose level. Key reminder as we go forward, your senses are going to be the best assessment tool. Everything else is an adjunct to help amplify those senses for you to make sound clinical decisions. First tool, you the provider. You are the single most important assessment tool that you have. Your knowledge that you gain through your education, your continuing education, and your experience in the field, your observation skills of the environment around you, the environment that the patient is, and your intuition or inclination or decisions based on historical evidence, okay, for how you're going to treat the patient or what's going on with the patient. So no tool is better than you, and every tool that you have at your disposal is designed to adjunct you and assist you in your clinical judgment and clinical making skills. All right, next tool that you're going to use, probably the most common tool that you're going to use, is your stethoscope. The stethoscope is designed to amplify your ability to hear sounds. So again, it's an adjunct to your ears and to assist in you being able to hear sounds that are pertinent in assessing the patient. You're going to use the stethoscope as an assessment tool for listening to things like lung sounds, abdominal sounds, heart tones, and also for things like taking a patient's blood pressure. And when we talk about the stethoscope, this is a precision tool and it has specific uses and designed with intention in mind. Okay. So let's take a look at the stethoscope and see the parts here. So first you have the ear tips. These can be solid plastic or soft rubber or latex. These go into the provider's ears for you to be able to listen. If you notice, they are curved. This curvature is designed to follow the ear canal, and the stethoscope, when placed in the provider's ear, should be curved facing toward the front of your face. Okay, so they should be curved and move forward pointing towards your nose, your eyes, your mouth, because that's the direction that the sound travels through your ear canal. Your ears don't go straight into the side of your head. They actually are slightly moved forward. These will twist, so you can grab the handle here and it will twist at this junction so you can adjust the stethoscope to get the best hearing for you. Okay. You come down the stethoscope, you have a tube. This PVC tubing may be a single tube, that's most common now, or it may have two tubes. In EMS, we try and avoid using dual tube stethoscopes because they tend to rub against each other in the back of the truck. And so you get artifact in your sound. That takes you down to the head of your stethoscope, okay? This piece here. There are a couple of different tools at the head of the stethoscope that you need to be aware of. Most stethoscopes will have two sides. So you can see that you've got a side here and a side here. By rotating the head of the stethoscope in either direction, it will activate one side or the other. So it's important that when you use the stethoscope for the first time, you twist the head of the stethoscope to make sure that it's facing in the correct direction. Some stethoscopes, such as this one over here on the right, only have a single direction. So those are not twistable or tunable to multiple sides. And we'll talk about that one here in just a second. There are two distinct ends to the stethoscope. You have this one here, shaded in blue. This is the bell of the stethoscope. The bell of the stethoscope is designed to listen to low frequency sounds. Your low frequency sounds are things like abdominal sounds, cord cough sounds, so when you're listening for a blood pressure, and heart tones, okay? Those are your low frequency sounds. So if you're going to be listening to heart tones, abdominal sounds, or assessing a blood pressure, you should be using the bell side of the stethoscope. The other side of the stethoscope, you can see here circled in red or the one in the green square, is the diaphragm. The diaphragm of the stethoscope is designed for high frequency sounds. These are sounds like lung sounds and trachea sounds. So if you're auscultating, and auscultating is the term used to indicate that we're listening to something with a stethoscope. If you're listening to or auscultating high frequency sounds, you're going to use the diaphragm. Okay. The diaphragm and the bell should be placed directly on the skin and should not be placed over clothing. Clothing obstructs the movement of sound, and you're not going to get a clear picture. Okay. Moving over to the one from the orange, on some of the more high-end stethoscopes, you may have something called a tunable diaphragm, and that's what you see here. That's why there's only one side. So with a tunable diaphragm, and you can see there's places for your fingers to hold here, the back of the head of the stethoscope, with slight pressure. So if you're just barely holding it to the skin, it will pick up low frequency sounds. And if you push down harder, it tightens the tension across the diaphragm and tunes to high frequency sound. So depending on the amount of pressure that you place on the stethoscope head will determine whether it's tuned for low frequency or high frequency. This is common in some of the higher end stethoscopes, such as like the Littman Cardiology, the Cardiology 2, Cardiology 3, and so forth. As far as what you need for an EMS provider, a very basic stethoscope of general quality that has a bell and a diaphragm is perfectly acceptable. A $30 or $40 stethoscope is really all you need. The problem with higher quality stethoscopes or more expensive stethoscopes is oftentimes you'll pick up a lot of ambient noise. The back of an ambulance is not a quiet environment, so you lose a lot of diagnostic capacity that you get with the higher end stethoscopes to the ambient background noise that you have in your work environment. The other piece worth noting here is stethoscopes are sized for body size. So you typically have an adult stethoscope, like you see in the main picture here. You may have a pediatric stethoscope, which is scaled smaller, and then you may have a neonate stethoscope, which is really tiny. It's important to use the appropriate size stethoscope for your patient. Because if you use an adult stethoscope on a neonate patient, you're going to get a lot of ambient sound and not be able to focus on what you need to be listening to. The next tool at your disposal is the blood pressure cuff. Blood pressure cuff, or sphygmomanometer, big long word that you typically see on these, is used to achieve or to acquire a patient's blood pressure. It's comprised of a couple of different pieces. You have the inflator here, or a bulb. You have the gauge that tells you the pressure inside the cuff. And then you have the arm band of the cuff. The arm band should be appropriately sized for your patient. You can see where it should rest over the artery, so it's placed on the upper arm. If you're on the left arm, this arrow here that says left arm should be placed over the brachial artery as it comes across the antecubital fossa. Likewise, on the right arm, you should place the artery at that arrow. It should be appropriately sized, and most of your blood pressure cuffs will have a similar size range on them. The end of the blood pressure cuff, so the very end here, when it's placed on the patient, should land somewhere within this range. If it doesn't fit in that range, you need a larger blood pressure cuff. If it goes too far in the range, you're going to need a smaller blood pressure cuff. These are calibrated to give specific readings when they're appropriately sized. Using an inappropriately sized blood pressure cuff, you're not going to be able to get an appropriate and accurate reading. As you can see on the screen here, it's a gauge. It's an analog gauge denoted in pressure. This is noted in millimeters of mercury. And you can see that you've got 20, 40, 60, 80, all the way up to 300 on this one. And then each small line in between indicates 2 additional millimeters of mercury. So for example, this one past the 40, one line past the 40 would be 42 millimeters of mercury. The next tool at your disposal is the pulse oximeter. The pulse oximeter typically goes over the capillary bed, and you can have a finger pulse oximeter. Sometimes they'll go on the earlobe or they'll go on the toe, okay? And that measures the percentage of oxygen passing underneath the sensor that is bound to oxygen. So hemoglobin bound to oxygen as a percentage, okay? This SpO2 is saturation percentage of oxygen at 96%, says that 96% of the hemoglobin that is moving underneath the sensor is bound to oxygen in the form of oxyhemoglobin. That gives you a 96% saturation. Most adults will be somewhere between 96 and 100. The PRBPM here is the pulse beats per minute, okay? Looking at what the heart rate is, or what the pulse of circulation is at the sensor, right? So it's getting a pulse of circulation at a rate of 77 beats per minute. The waveform here underneath indicates how well the oxygen sensor is picking up readings. And you can see as it's moving up and down as it goes through a period of time. If a patient has a low oxygen saturation, that would be a time that we would apply oxygen as a clinical intervention. The glucometer. The glucometer is designed to measure the amount of glucose present in a patient's blood. This is taken at the capillary, and it's often referred to as BGL, or blood glucose level, or CBGL, capillary blood glucose level. And it's measured in milligrams per deciliter. Okay. You have a couple of devices here. You have a test strip. They typically come in containers. They're placed inside the glucometer, which usually powers on the glucometer. You'll have a capillary bed here at the end where the blood will go. And you typically have a lancet device. You'll clean the patient's skin, typically the finger, with alcohol. Let it dry completely. Puncture the skin with the lancet device and place the capillary test strip into the drop of blood that's present on the patient, and that will give you a reading. Other vital signs. We've talked a lot about AVPU. That's a level of consciousness assessment. Remember, that's alert, alert to verbal, alert to pain, and unresponsive. It does not determine a patient's cognitive level, only their level of consciousness. We'll go further to assess this using something called the Glasgow Coma Score. And this is a score based on the level of consciousness of the patient. And so you can see here it's comprised of 3 categories. You have eye opening. If their eyes are spontaneous opening, they get 4 points. To sound, 3. Pressure, 2. Or none, they get 1 point. Verbal response. Are they oriented when they talk to you? They would get 5 points. Confused, 4. If they're making words, but they're really not sensical words, they're not relevant to the conversation, or they're inappropriate words, they would get 3 points. If they're making incomprehensible sounds, no words, that would be 2 points. And if they're making no verbal response, they would get 1 point. Motor response is the other part of the assessment. If they obey commands, they're able to stand up and move appropriately, they would get 6. If they're localizing painful stimuli, and what I mean by that is if you grab their wrist or you're palpating on something and it hurts and they bring their hands towards it, okay, that's going to get a 5. If they withdraw from painful stimuli, so they just kind of push away or try and move away from the painful stimuli, they get 4 points. Abnormal flexion is decorticate posturing, and we'll talk more about that in trauma. But it's a global body positioning where the hands and the feet are curled inward toward the body. That would be worth 3 points. If it was abnormal extension or decerebrate posturing, that would be worth 2 points. And if they have no motor movement, that's worth 1 point. Important things to note here, that a Glasgow Coma Scale will go as high as 15 and as low as 3. Even an unresponsive patient with no movement whatsoever, it's a Glasgow Coma Score of 3. For the advanced level providers, we'll use the GCS in combination with other factors, including blood pressure, to help determine things like revised trauma scoring later. Pulse. For a pulse, this must be palpated. You can't obtain a pulse from a cardiac monitor. You can't obtain a pulse from an SpO2 monitor. You can get a rate from those things, but you cannot get an actual pulse. The word pulse implies that it is perfusing an artery at a specific point. So when you say they have a radial pulse, that means you feel the pressure at the radial artery. That becomes important because that correlates to a significant number in the blood pressure or the mean arterial pressure. So we know that if they have a radial pulse, their blood pressure typically is above 80 systolic. Okay. Typical rates for adult pulses are 60 to 100, but understand that this varies tremendously by the patient's sex, by the patient's age, and can move in and around, and their athletic fitness or their cardiac fitness. Pulses can be regular or irregular, meaning they can occur at a regular interval, or they can be erratic in their interval. We will measure amplitude, which is how strong the pulse feels at your assessment point. Again, another reason it's important to reach down and feel for a pulse. It can be termed bounding, which is a strong, excessively strong pulse, or it can be thready, which is a weak pulse, or we would classify otherwise as normal. As far as assessment of your blood pressure is concerned, we talked about the tool that you were going to use. But when you assess the blood pressure, the method that you will use is you will place the cuff on the patient. You will place your stethoscope over the artery that you're auscultating with the bell side, not the diaphragm, and you will inflate the blood pressure cuff until somewhere around, typically above 80 millimeters of mercury, and you're going to listen for a pulse sound or a Korthoff sound, and that's the sound of the blood pushing against the artery that you hear in your stethoscope. Get a listen for that, and once you hear that, you're going to continue to inflate the cuff until that sound goes away. Once that sound goes away, you're going to slowly release the pressure in the cuff until you hear the heartbeat return, or the Korthoff sound return in the stethoscope. The first time you hear that heartbeat, you're going to look at the number on the gauge of the stethoscope, and that's going to be your systolic number. You're going to continue to listen to the heartbeat in the stethoscope, watching the gauge as it falls until the last time that you hear the heartbeat. The very last number that you heard a heartbeat at will be the diastolic pressure. It's all pressures lower than that, you don't hear the heartbeat sound. That's your diastolic pressure. Your systolic pressure is the pressure that's exerted on the vessel during systole, or the systolic contraction of the ventricles. Okay? The diastolic pressure is the blood pressure that exists in the vessels in the artery when the heart is at rest. So systolic pressure is force pressure when the heart contracts. Diastolic pressure is the resting pressure within the heart itself, or within the vessels. As far as assessment of respiratory rate, we're also going to assess rate and quality when we get a respiratory rate. The rate requires you to count the number of respirations per minute. We typically do that by watching the chest rise and fall for a period of 15 seconds and multiplying that by 4. That gives you a respiratory rate. To assess quality, you need to feel, using your hands, for adequate chest rise and expansion. You can do this by placing your hands on the lateral sides of the patient and feeling the chest rise and fall, or the chest wall expand during inspiration and contract during exhalation. Normal respiratory rate for an adult patient is 12 to 20, but again, that can vary widely with age and health quality or cardiovascular status of the patient. The rate of respiration is irrelevant if there's no quality of respiration present. And what I mean by that is a patient can be breathing 12 times a minute, but excessively shallow, and they will not be breathing sufficiently. The other thing that you will want to look at when you assess respiratory rate is the respiratory pattern. We'll talk about many of these as we talk through various pathophysiologies later in the course, but you can see there's many types of respiratory patterns that we want to be aware of, particularly tachypnea or fast breathing, bradypnea, slow breathing, Cheyne-Stokes, which is a repeating irregular pattern, okay, agonal respirations, and Kussmaul's, which is deep, rapid breathing. You'll want to keep an eye on those. Those will be really important later. As far as assessing the SpO2, we've already talked about it being the oxyhemoglobin percentage. You can see that you have the perfusion waveform here. This would be a normal signal, normal waveform. Low perfusion will have a low amplitude signal. If there's noise or motion artifact, you can tell by the waveform itself. So the waveform helps you make sure that you've got an adequate signal going to the device, and the reading is your SpO2 percentage. Things can inhibit, so this is a light-based sensor. If you have things that will occlude that light from going through the capillary beds, you're going to have a hard time getting an accurate reading. That includes things like nail polish, okay? Skin color can also help you as an indicator tool here to make sure that the patients are oxygenating appropriately. And then low perfusion. So if they have a really low blood pressure and the capillary beds aren't perfusing, you also may not get a good reading here. As far as glucose reading goes, this is assessed at the capillary bed. You can see here is a chart of normal glucose readings. Understanding, just like the rest of the vital signs, this can vary widely among your patients. Your normal adult patient is around 100 milligrams per deciliter. If the patient does have a history of diabetes, they will either have a log book, typically, or you can access the log in the machine to see what their normal glucose ranges may be. Another reminder that the lancet used to draw blood from the capillary bed from the patient is a biohazard sharps device. That means that when you're done using it, you shouldn't set it down. It should immediately go into the sharps container. Thank you guys for tuning in, and we'll see you on the next one.